Perfectly.
Wonderful, wonderful. Good afternoon, everybody. I know it's a holiday for you there, so thank you for coming along to this presentation. So I'm a consultant orthopedic hip and knee surgeon. I have been a consultant for 19 years. I was appointed in 2005. And at that time, as you heard, I was the first Black woman to become an orthopedic consultant in the United Kingdom. I have done all my training in England. I was born in Guyana in South America. I did my primary education in Guyana, but my secondary education in England. Went to University College of London and did most of my training within the London region. I, however, went to Canada and Australia for fellowship training in joint arthroplasty and hip arthroscopy. I also became the first woman in Europe to perform microrobotic surgery in 2018. So, as you heard, my specialist interests are hip and knee pathology, knee arthroscopy, that's keyhole surgery to the knee, robotic surgery, and minimally invasive surgery. I work both within the National Health Service as well as the private sector, and I'm affiliated with a number of private hospitals, the Cromwell Hospital, Harley Street Specialist Hospital, the Clementine Churchill, and the Chiswick Medical Center. Apart from my clinical work, I am a medical examiner both for Imperial College in London, but also for the University of the West Indies in Trinidad and Tobago. I have a keen interest in increasing diversity in surgery. Of course, being the first Black woman, I realized that there was a lot of work to be done. That was only 19 years ago. To date, we now have 6 other Black women in the UK. And Black surgeons as a whole make up about 1% of the orthopedic consultants. So much to be done. But orthopedics of all the surgical specialties is the surgical specialty with the least diversity. So not only are they in terms of ethnicity, but also in terms of gender. And so there's a lot of work being done within that field, and sitting in a number of organizations to try and improve that. And also another area of special interest to me is women's health. I think that's an area that's been overlooked, and particularly women around the perimenopausal and menopausal time of their life do have increased joint pains, and the importance of that is now being recognized. So that's an area of special interest for me. Now, what has happened there? My slides have stopped. Okay, there we go. Fine. Lovely. So today's talk, let's get on to the meat of the talk. It's really to talk about the current advances, of which there are many. Patient optimization, refining our surgical technique, choice of implants, implant materials, orthobiologics, detecting and preventing infection. You can read it for yourself. But in the interest of time, I'm not going to speak much on orthobiologics today. I will touch on it, but orthobiologics are, in essence, substances that are naturally found in the body that we can use for treatment of certain conditions. But I'm going to speak to you briefly on all the other things that are highlighted. So let's start with patient optimization. The first part of patient optimization is really looking at the patient's health. And for you, if you want to maintain a healthy lifestyle, and that includes having healthy joints and muscles, it's about having a good diet. And we really want to focus on increasing the intake of foods with high antioxidants because they have a protective function on the workings of the joint. And foods that have green leafy vegetables, for instance, kale or spinach. Berries are very high in antioxidants. Walnuts also have it, and things like liver. So you want to be making sure that you have a balanced diet. You want to make sure that you're having enough dairy, that is calcium, and getting enough sunlight, so vitamin D, something that unfortunately we don't get enough of in the UK. So we want to make sure that all those things are present in your diet. And by having a good diet, not only will it improve the state of your joints and your muscles, but it will also keep a control of your weight. Because if you have increased weight, you're putting more force through the joints. So you want to make sure that you manage your weight as well. It's important to keep the joints well mobilized, and that movement of the joint is very important pre or should you have surgery, post surgery. And because it's important that you know that the most important predictor of post-operative range of movement is pre-operative range of motion. So if you have a stiff joint going into surgery, you're going to be stiff after. Okay, the surgery gets rid of the worn surface of the bone. It decreases the pain, but it won't necessarily give you the range of motion if you're stiff beforehand, unless there's been a significant mechanical block to your movement. And similarly for hip surgery, strengthening the muscles around the buttock and your core strength are very important for your post-op stability and mobility. So it's important that you focus on that prior to any intervention. You want to take adequate painkillers because by having a pain-less joint, or reducing the pain to joint means you're going to exercise more and you're going to do all the things that I've just mentioned. So having adequate analgesia on board is important. Something that's often overlooked is our footwear. Having appropriate footwear is essential. It affects the alignment of the limb, which then impacts the forces going through the joint. So maintaining good footwear, particularly making sure that the arch under your foot is well supported. For the knee joint, an additional knee support or knee brace may be beneficial to be able to enable you to carry out the necessary exercises that are important. Now, for those who are medical practitioners who may be listening, if you're going to refer a patient for an intervention, you have to make sure that they're fit enough as possible prior to that intervention. So looking at things like their hemoglobin, making sure that's adequate, because during surgery, you're going to lose some blood. Vitamin D and calcium, that's particularly important here in the UK, where we don't get enough sunlight, and patients' vitamin D is often low, which means that the bone quality is suboptimal, and that can lead to increased fractures around the time of surgery. So you want to make sure that that's within the normal range. You want to make sure that any underlying medical conditions are stabilized. Conditions such as sleep apnea, where patients have difficulty with sleeping, they have been known to be associated with increased complications in surgery. Of course, if you've got any underlying cardiac or respiratory problems, that can affect the anesthetic. So you want to make sure that the patient is optimized from those medical conditions. And smoking, that's important. If you can encourage your patient, or if you yourself are going forward as a patient, try and stop smoking. It will also, that will impact the anesthetic. If you're going to have a general anesthetic, then you can have increased problems there. But also the radicals produced from the cigarette smoke can also have a negative effect on the cartilage. So it's important that if you can, that you give up smoking. You may ask, well, what are the role of injections? The injection really is a form of pain control. It's not really a way of managing a patient's health. But obviously, if the patient's pain control is improved, then they can do more exercises. So the injection may have a role. And there are numerous injections available. A local anesthetic and steroid, often given in combination. The steroid is the active ingredient. The local anesthetic is just there to take off the edge of the pain. And that can reduce the inflammatory aspect of the arthritis. And therefore, with reduced pain, there may be increased function. Another injection that we have is hyaluronic acid. That's a natural substance that's formed in the body, the natural lubricant of the joint. That's actually formed by the joint cartilage. And so when you have worn cartilage, it means that you don't produce enough of this substance, or the substance that you produce is of poor quality. So we're just putting back something that's normally there. So just lubricating the joint. It doesn't change the arthritic surface, but that may improve your range of motion. Platelet-rich plasma, I talked about orthobiologics. This is one of them. This is taking your blood, centrifuging the blood, taking out the red cells, and what you're left is with is called a plasma, in which that contains white cells, platelets, and also cells known as stem cells, cells that have the potential, the healing potential within the joint. However, I have to say the studies for its efficacy are quite weak. But in some patients, we use that as part of our armory when other things have failed. It's usually better. The function is usually better once you've actually prepared the joint to receive the platelet-rich plasma rather than just injecting it blindly into the joint. But that's something that's an option. And then the last injection, that's something that's really become quite popular in the last 18 months, is something called arthrosamid. And that's a polyacrylamide hydrogel. It's a structure, it's a substance, it's a thick gel substance that actually coats the lining of the knee and dampens the inflammation, and thereby reduces your pain and increases your function. And the only difference between this and the other injections is it has a longer duration of action. The others are much more unpredictable in terms of action. Some don't work at all. They maybe last a few weeks, months. Some patients, if they're lucky, may get a year or so benefit. But the arthrosomid has seemed to, of studies lately have suggested that its efficacy can last for 3 years or more. And so that's quite an exciting breakthrough, and something to be considered for patients who are either unfit enough to go through surgery, they're in a lot of pain, but they're not quite ready for surgery. So this is something to be considered. And if you have the gel, it becomes incorporated into the lining of the knee. It doesn't preclude you from having joint replacement later on should you need it. So I think that's the most exciting thing that's coming on the market in terms of pain control. And then you've got the patient's expectation. They want to have a good outcome from surgery. And the patient often bases what goes on inside the knee or the joint on what they can see on the outside. And so we've got to improve our techniques in the way that we close the joint. I personally, I trained in plastic surgery as part of my training, and so I take time to stitch the joint. A lot of my colleagues quite like using clips. I think the scar is a little inferior compared to the scars that I can achieve. But something that's come onto the market very recently is a type of mesh and glue. So those, if you don't want to have, because of course, if you're taking time to stitch, that takes up operative time. And when you're in a facility where they're trying to get as many cases through as possible, you want to try and see if you can speed up the surgical time. And so the mesh and glue I have found seems to be working as well as stitching the skin. And you're getting a nice clean scar, as I've shown you here. Patient genotyping. This is something that is not widely used, but can be and is being more and more investigated, and that's genetic manipulation. And looking to see whether we can try and improve patients' resistance to infection, because for an arthroplasty surgeon, someone doing joint replacement, that is our biggest worry, is infection of the joint. And so if you can improve a patient's ability to fight infection, then that would be quite exciting. And this is what's being investigated. And also trying to see if we can delay the onset of arthritis. But these are not common treatments. These are just things that are being looked into currently, very experimental. We know that whilst someone's in pain, if they have an arthritic joint, it can have a psychological impact. And particularly here in the UK, I don't know what it's like in your part of the world where there are prolonged waiting times to get to surgery. The psychological impact cannot be overlooked. And we do have a lot of organizations which can support the patients. There may be those in your area which you should explore if required, and they can give advice on how to manage. You can speak to other patients who have gone through similar conditions. If you're offered a surgical procedure, you may be able to speak to someone who's been through it, etc., and can outline what to expect. I mean, your surgeon should be outlining that, but you may want some other support. In terms of treatment, the options here in the UK are to go through the National Health Service, but if you're not eligible for that, then you get your treatment through the private sector. Often that means that you can get a treatment at a time suitable to you, with the surgeon of your choice, and at a quicker time. And patients may have private insurance, which can help facilitate that. But if you don't have insurance, then there are self-pay packages that most of the hospitals offer. And also there's a private insurance company called Medbell Insurance that also offers competitive packages. For me, the education of the patient is key. And it's important for them to understand what's involved in their treatment. And whilst you try your very best to give the patient that information during the consultation, sometimes it can be stressful to hear that you require a surgical procedure, and the patient doesn't always take everything in. So I've developed an app where patients can digest information at their own pace. It outlines the procedure. It talks about particular exercises that patients may be required to do. And particularly for those ones that they need to do after surgery, they can start familiarizing themselves ready for the time of surgery so they can guarantee the best outcome. And I'm happy for you to access it. You'd have to go onto Patient Journey app. You'd find that on the App Store. And then once you find Patient Journey app, it asks for a healthcare provider, put in joint replacement surgery, and you'll be able to find relevant information. So in terms of surgical techniques, I'm not going to talk about surgical approaches because the actual approach means the actual anatomical dissection towards the joint. That's not what we're covering here. We're talking about how do we facilitate implanting the components. And it can be done in the conventional way where the surgeon um, uses certain landmarks in the patient's body, and having been well trained and where the appropriate place to place the implants, then they would do so. But you can be assisted by navigation or a robotic device. And then you can use a conventional incision or a minimally invasive, which I use. So the benefits of a minimally invasive approach is there's less dissection, which means less trauma to the patient, therefore less post-operative pain. Um, Better cosmetic scar, but it's not really about the scar for me. The importance is getting in a well fixed implant that's going to last the patient for a long time. But what I'm concerned about is minimal blood loss and minimal tissue trauma, which can lead to less postoperative pain and a faster recovery. So what's the difference between a navigated surgery and robotic surgery? Both are there to improve the patient, the surgeon's accuracy and reproducibility in placing of the implants. The navigated one, it both require information that's downloaded by doing special scans, either CT or MRI, of the patient's anatomy. That data is inputted into the computer of the device, and then with the navigated device, you have a screen, and it gives you a sort of color code as to when you're resecting sufficient bone. So it changes through different, and you want to get down to the white color, then that's enough bone. If it changes to red, then you're taking off too much bone. So it's a very hand-eye coordination thing. The robotic device works in a similar way, but instead of you having to rely on the visual cue, the actual device will cut out at the amount of bone that you're supposed to resect within a millimeter of accuracy. So once you've resected the amount of bone that you've pre-planned, it will cut out and will prevent you cutting more bone. Now, having a robotic device or a navigated device doesn't prevent you making mistakes, because you first of all have to input information that you have gathered from your investigations into the device. So if you put in the wrong information, you're going to get the wrong information out. And so we cannot just rely on these tools to do an effective operation. The surgeon has to be well trained and to be able to recognize when something is not quite right in surgery. And thereafter, you have the ability to reset the parameters within the device, and thereafter it will act according to the new calibration. So the different systems that I use here in the UK that are widely available are there's different companies and they're very different devices, but they act in a similar way. The one in the middle, the Navio, is a navigated device. So that's you see a screen there in the middle of the picture, and the surgeon is looking at that screen. You have on the patient these adaptive devices, which are recognized by the computer as to where the limb is in space, and therefore it forms an image of the patient's joint, and from there you can then resect the amount of bone. As I said, the one on the left, the Mako, and the rows on the right, they actually will cut out and stop you taking off more bone than is necessary. So that's just me there doing a navigated knee replacement, and you can see me. I'm facing towards the screen. We've got these stereotactic devices that are on the patient's limb, and that's being picked up by the monitor opposite above the screen. So what are the benefits of using a navigated versus conventional knee replacement? The conventional knee replacement is where you're just relying on the anatomy that you know, and you try and best customize your cuts to that patient. And there's certain guides and jigs that we use to try and do that. And in most cases, I would say, one gets a very good outcome. So it's, for me, I think these devices come into the fore when you have abnormal anatomy. If someone comes with a gross deformity, that's when these devices really come into the fore. If you have a straightforward deformity, I'm not sure that it's absolutely necessary. So here we are, and to the left in both of those images is the navigated outcome, and you want to be as close to zero, which is the normal. And the first one to the left, we're talking about the joint line. So you have the patient's normal line where the joint normally sits. And obviously, when you have arthritis, the joint line shifts because you lose cartilage and sometimes bone. And you want to replace the joint line back to neutral. And we can see that the accuracy of the navigated device is much closer to zero. Well, I should say closer, I don't say much, but within a couple of millimeters, because we're only talking of millimeters here. So that's about 2 millimeters, and the other one, let's say, is 3.5 millimeters. So it's not a huge difference. And what we don't know yet, because it's too early, is to whether that difference is going to have a long-term outcome. We predict that if we get as close to the patient's normal anatomy as possible, that will lead to longevity of the implant and that the device will last a bit longer. But I'm afraid at this stage, we don't have that information to say that's the case. But all we can say is that with this device, we are getting as close to the normal as possible. But time will tell whether that leads to the implant lasting a bit longer, because ultimately that's what we want. We want to be able to put in an implant and it lasts the patient forever. So there we are. So one is the joint line, the other one is the slope. Everyone's joint, the joint isn't a complete horizontal line, there's a slight downward slope. And again, with the navigated device, you get nearer to the normal as you can, compared to a conventional approach. So using the navigated system or robotic system, you get improved component alignment and mechanical access, where the weight-bearing portion of the prosthesis is in relation to the bone. And because the alignment is better, then you may get better balancing of the soft tissues around the range of motion, which should hopefully lead to better range of motion. And so functionally, the patient should have improved range of motion, decreased pain, and hopefully that would then lead to a better outcome. Now, how does that work in the hips? It works in a very similar way. When we compare conventional to robotic assisted hip replacement, this study looked at the placement of the cup. In a hip replacement, you have two components. You've got the cup and you've got the stem. And the cup, the position of the cup can really impact the risk of postoperative dislocation. And that oblong that you see highlighted is the area where several studies over many years have shown is the best place to put a cup to prevent the risk of dislocation. And the gray area is if you make that area even smaller, so you really increase the zone of accuracy, but the overall outline is where ideally one wants to place a cup. And you can see that when you look at the conventional hip replacement on the left, that most well-trained surgeons, even without the use of a robotic device, are getting the cup within that zone of safety. But there are a few, however, are outliers, and it may be that those are low-volume surgeons. They're not doing very many cases, But when you look to the right, where they've used the device, then they're getting it within that zone of safety. Okay. So, but we have learned of late that even though you've placed your cup within that zone of safety, with or without the robotic device, that in itself is not enough to prevent dislocation. By and large, it does improve it. But if patients have significant spinal pathology and the spine is very stiff, then that doesn't allow the pelvis to move in such a way that the femoral stem and head remains under the acetabulum, and so there can be a risk of dislocation. So even with a robotic device, you cannot obliterate the risk of dislocation if the patient has significant spinal pathology. But it can assist you because you would put in certain markers that you've taken from the spinal alignment into the device, and that will help you to then decide the optimal place for placing of the cup. The device can also assist you with the right height in which to cut the femoral neck, because where you position your prosthesis in relation to the cut bone will determine the patient's leg length. And during surgery, alterations in leg lengths can occur. And so we want to, at the end of surgery, have patients have equal leg lengths. They want to be balanced. Now, if you've got two arthritic joints and you only replace one, then there will be a leg discrepancy temporarily until the other hip is done. You can't get the legs balanced if one remains arthritic. It can also help determine the version, i.e. the alignment of the stem within the femoral bone, and that also has a bearing on the risk of dislocation. So these are things that we can achieve. But as I said to you, as a well-trained surgeon, I do not feel that this device is of any adds more to what I can achieve in the straightforward cases. If there is a complex patient, there's significant spinal deformity, there's significant pelvic or femoral disturbances of the anatomy, then this is where this really comes into the fore. In terms of implants, there have been different things have become fashionable at different times. We at one point tried to have gender-specific implants because we know that the anatomy of a woman varies in relation to the man in terms of the size of the bone and also the comparison of the medial lateral versus AP diameter. And so getting patient-specific implants was thought to be the better thing to do. But in fact, it meant that you didn't have the flexibility in managing your theatre list. If a patient canceled on a particular day for whatever reason, they became unwell at short notice and you had to draft in another patient, you wouldn't necessarily have the right equipment available. So we've now gone away from that. That's sort of gone away from being fashionable. And what the companies have started doing is doing a lot more in between sizes than they had before, so that you're bound to have something that will fit either sex. Ligament sparing, in terms of knee replacement, usually the anterior cruciate ligament has to be sacrificed. There is a posterior cruciate ligament as well. And some surgeons believe that the posterior cruciate ligament should also be sacrificed because in the presence of arthritis, the ligament does not function normally. My philosophy is that one should leave as much of the patient's anatomy intact as possible. And so unless there's gross deformity of the knee, I tend to spare the posterior cruciate ligament. But that's a personal feeling. Implants may be anatomical or non-anatomical, i.e. they can actually match the shape of the patient's bone, or they can be a set shape and you put it on as best as possible onto the patient's limb. I'm not actually found a significant difference, nor have I seen in studies any studies that suggest there's any significant difference between the two. But it was thought that if you had something more anatomical, it would help with the soft tissue balancing and so on. As long as the prosthesis remains within the limits of the bone and doesn't encroach in the soft tissues, then it shouldn't really cause a difference. In terms of hip replacement, the dual mobility hip. Now, what does that mean? I'll show you a picture in a minute. The conventional hip replacement is a cup and a stem with a ball on top of it. But you are then limited as to the size of the ball depending on the size of the patient's acetabulum. And women that have smaller pelvises, they will have smaller cups and therefore you're restricted to a smaller head size. The problem with that is that the smaller head sizes are more associated with the risk of dislocation. And ideally, one wants to get as large a head as possible. By having a dual mobility hip, it means that you can have a thinner shell on the cup side, allowing for a larger head. And so what you have is a metal or ceramic head inside a larger plastic head. So you have the plastic head against the metal cup. Now, there is another version called the hip resurfacing, where you have a large head made of metal against the metal cup. But the problem is that the metal ions at any joint where there's movement between two joint surfaces, there is debris formed. And the metal debris formed between the metal against metal can lead to chromosomal abnormalities, and there's a risk of potential cancer occurring. Now, this has not been shown to the chromosomal aberrations have been detected, but nobody so far has developed cancer. But it is a concern, and therefore it's been advised, certainly in the UK, that those metal and metal replacements should not be used in women of childbearing age because the metal debris can cross the placenta and get to the fetus. However, in older patients, it's still very much used. And one of our famous tennis players, Andy Murray, he had a hip resurfacing carried out. As I said, because the larger head gives more range of motion and a decreased risk of dislocation. But it's because of the problems with the metal debris, because that can lead to chromosomal abnormalities, but also because the metal debris can set up a severe inflammatory response, which can then lead to loosening of the implant. That the people are going away from the hip resurfacing, but they still want to keep the benefits of having a larger head. And so the dual mobility hip has been developed. Implants can be modular, i.e., you have the stem of the prosthesis, let's say the femur, and then you have the neck part to which the head is attached. And in people, the anatomy, if you were to gather a group of people and do a study, the angle between the neck and the shaft of the bone varies amongst patients, and there's possibility of having implants with variable necks, so you can more match the patient's anatomy. That became very popular some years back, but we're moving away from that because wherever there is a coupling between two bits of metal, there's a risk of metal debris being formed. And so that fretting that can occur means if it's happening at several places, because you're going to have that between the neck and the ball of the head. If you have that, again, another junction between that stem and the shaft, then you can produce more debris, which can lead to problems later on. So modular components are now becoming less fashionable. In terms of the materials are standard that we use in orthopedics. They're either metals, plastic, or ceramic. Ceramic is one of the toughest materials we've got. Therefore, there's less wear debris being generated because that wear debris can set up inflammatory reactions that can lead to loosening of a prosthesis. So ultimately, we want to reduce the amount of debris being produced and also the particle size of the debris, we want to make as small as possible. Essentially, we want to try and prevent any wear at all happening. And so studies are always being done to try and improve our materials so to reduce the amount of wear. But the other thing that we want to do, apart from reducing the wear, is we want to have a modulus of elasticity of the material very similar to bone. Because if the material is stiffer than the bone, then you will get stress occurring between the two areas and a fracture can occur. So we wanted to use metals that are very similar, and titanium has a more similar modulus of elasticity to bone compared to, say, stainless steel, which was used previously. So more implants these days are made of titanium and other alloys such as vanadium, etc. I talked about the particle size already. And then the porosity. We want to use materials that are porous, i.e. they will allow the bone to grow into the prosthesis and therefore making it becomes fixed and therefore less likely to loosen. Because implants can be put in with or without cement, and cement is like a grout, which will get loosened over time. But if we can use porous metals and the bone grows onto it, then the prosthesis is then fixed for life. Just some pictures here to the left here. We've got, this is a cemented implant. And so this would be inserted with cement, and this is a plastic cup which will be inserted with cement. This is the resurfacing, which I told you is quite a large head. So when you make the cut, like on this diagram, the cut is made right to the top, just below the ball part, and the prosthesis sits on there thereafter. Conventional hip replacements, other hip replacements, the cut is made further down here. And so because we were having problems with the metal resurfacing and the metal ions and the inflammatory reaction and the chromosomal abnormalities, we've moved to having different prostheses. One where the larger head is actually made primarily of a plastic, and it now has a titanium coating on it. This is something that's very new. This is just coming out in the market. Or I talked about a dual mobility, where you had a large head, but inside was a smaller conventional prosthesis. So here's a dual mobility. You would have the stem. This is an example of a modular stem. You have the stem here and the different necks that can be put onto that to match the patient's anatomy. then you'd have a standard head applied, and on top of that, a plastic cap, which is much larger than the standard head that we'd be using in hip replacement. And by having a larger head, there's a less risk of dislocation. Different types of bearing surfaces. You can have ceramic head against a ceramic back metal liner, ceramic, yes, a metal back ceramic liner, I should say, a metal head against poly. We've talked about metal and metal with hip resurfacing. This implant here is a special implant for revision surgery. We wouldn't use that in a primary. The benefits of ceramic bearings is that you get less wear debris, as I've mentioned. We tend to, because it's a more expensive implant, we tend to use that more in younger patients because if the implant's going to be in there for longer, then over time you're going to generate more debris. So we want to reduce that. So we tend to reserve that for younger patients. In the knee replacement, depending on whether you sacrifice the cruciate ligament, there are different devices. So with the anterior cruciate ligament, which is always sacrificed, you can have a flatter tibial tray. But if you take out the posterior cruciate ligament, that makes it less stable, and therefore you have to have a stemmed implant. So this stem fits in the box of the femoral component, and that gives itself some inherent stability. The knee, unlike the hip, is very much dependent on the ligaments and soft tissues around it to balance it. And so that's critical that you look after the soft tissue envelope of the knee whilst doing the surgery. Within the hip, yes, the soft tissues, the muscles and so on are important, but the actual shape, the anatomical shape of the cup of the acetabulum and the femoral head it's more inherently stable than a knee replacement. And then in terms of a knee replacement, you can have a total knee replacement or you can have a partial. And a partial means that the part of the joint that's involved, you can just replace that, whether it's between the femur and the tibia or between the patella and the front of the femur. This is an example of an anatomical base plate because the medial side of the tibia is larger than the lateral side, or a standard one where the size of the implant is the same. And I've said studies don't show any obvious difference between the two. For any surgeon, what we want to do ultimately is to prevent infection. That's the key. We want to put in an implant that's going to last our patient. And so how do we prevent infection? We want to give appropriate antibiotics. And different hospitals will have different regimes. In my hospital, we give a very large dose of antibiotic at the time of induction of the anesthetic, and that's it. Historically, I used to give one dose at the time of induction, and then in the first 24 hours after surgery, we'd give more antibiotics. But the microbiology department has done some studies and shown that one large dose is sufficient. But it doesn't matter whatever the regimen is in your particular institution. The key, though, is meticulous technique, the way that you prep the patient before the operation, the way that you drape your attention to being very clean, reducing the amount of people in the operating room. These are all very important in reducing the risk of infection. And if you can be very expeditious in the way that you do the surgery, you do it very slickly, so the wound is open for a shorter period of time, then that's less time for bacteria to get in. Now, for those patients who have a depressed immune system, we can enhance it. I've never had to do that, but there are vaccines that one can give to improve a patient's immunity, particularly if there's a particular organism that the patient may have difficulty mounting an immune response against. So we can do that. But where most of the studies are taking place now is trying to eradicate the biofilm. Now, what's a biofilm? It's like a shield that bacteria produce. They have this coating around themselves, like their own body armor, and that prevents the antibiotics penetrating and therefore destroying the bacteria. And so all this work that's being done at the moment is trying to get an antibiotic developed that has the capability of really penetrating that biofilm. And if we can successfully do that, then it means that if someone has an infection, we wouldn't have a deep infection, we wouldn't have to go and take out the implant. Currently, because there's no way of the antibiotic penetrating all the bacteria, and some may be deep within the component. Therefore, in order to really be sure you got rid of the infection, you often have to take out the whole implant. But if we can successfully have an antibiotic that can successfully penetrate the bacteria, then we wouldn't have to do that. Because That's big surgery. It often takes a long time. There's often damage to the soft tissues, and the secondary surgery will never be as good as a primary operation. So the patient won't have as good an outcome. So we want to avoid that where possible. There are different ways of detecting infection, and there are different scoring systems that are used to really um, decide whether or not a joint is infected. Certain things are very obvious. If the patient has a wound and is draining pus, then obviously it's infected. The joint is warm and hot. The patient has a high white count, high inflammatory markers. There's certain things that, but sometimes you may not be sure. The patient may just have a little bit of pain and swelling, but the inflammatory markers may be normal, and so infection may be hard to detect. Certain things are better at detecting infections. Certainly, biomarkers. These are peptides that are produced by the white cells and the macrophages, the body's own protective cells that damage the bacteria. So these peptides would be only produced in the presence of an infection when these cells are trying to engulf and digest the invading organism, whether it be bacterial, viruses, or fungi. And so if there's a raised level of those biomarkers in the blood, then that's an indication that there's an underlying infection. And so alpha defensin and the other defensins I've mentioned, these are the most accurate things that we've got. The leukocyte esterase strips are they're good. Those are the ones we use when you do like a dipstick in someone's urine and it has a strip in different colors. But often that can become contaminated with blood and debris, and so we can't rely on the findings. But if you can get a nice clean sample and use that's very helpful and let you know whether infection is present or not. And so post-operative optimization, look, as I mentioned before, in terms of education of the patient, that's the key. The patient needs to understand what to expect. It's between the surgeon and the patient. You have to come to a decision on making sure the patient has the appropriate expectation for the surgery. Some people expect to regain absolutely full range of motion and to regain their full youth. That may not be possible. And that doesn't mean that you've had a bad outcome. As I said, the most important predictor of post-operative function is preoperative function. So if you're stiff before, you're going to be stiff afterwards, but the joint may be painless. Therefore, that in a sense is a good outcome, but you may feel disappointed because you want to regain full movement. So it's about setting the right expectation. And that helps with, so I think a patient has to be appropriately educated so they can be appropriately consented for the procedure. We have to make sure that the patient's analgesia is appropriate, and that analgesia begins intraoperatively. And during the time of surgery, when I'm operating, I use a special cocktail which is injected right away from the bone up to the skin, and that gives great postoperative control. And so these are some of the advancements that we have is different techniques to improve pain postoperatively. Nerve blocks as well are also done by the anesthetist. So targeted nerves are also given an injection. But the physiotherapy, commencing preoperatively and continuing postoperatively, is really key. So how do we reduce the pain? We want to make sure that we handle the tissues very well. Preoperative use of antidepressants and anti-anxiolytics, so drugs that treat anxiety and depression, given that around the time of surgery and perhaps a short course afterwards, can actually, it improves the patient's mood and can therefore decrease their requirement for some of the stronger painkillers, which may have side effects. My intra-articular cocktail includes Narapin, which is a long-acting local anesthetic, steroids such as ketorolac and kenolol, morphine, and adrenaline. Adrenaline constricts the blood vessels, allowing the injected substance to stay in the area for a lot longer. And the clonidine acts in that way as well. So it's a really good cocktail, and therefore the opiate requirement post-operative is reduced. And the opioids that I tend to give is a long-acting steroid called OxyContin or Octinol, but it doesn't matter. Some people use codeine. It's about finding the right post-operative analgesia for the patient, because some can tolerate one drug and some not. And so around the time of surgery, I work closely with my anesthetist as well as the pharmacist to try and get the right pain medication for the patient. So treatment is very much individualized. And with the right pain medication, you can get patients moving very quickly after surgery, getting a good range of motion, and already starting to engage the quadriceps muscles. Here we are. You can just about get the heel up off the floor, and you need the quadriceps muscle to do that. And the quadriceps muscle is a muscle that's cut during surgery, so a lot of patients often aren't able to do that. But with the right pain medication on board, they're able to do that. And it's important that when you send the patients home, particularly with knee replacement surgery, which is a very painful operation, that patients have adequate analgesia, because the best outcome comes from early movement. Okay, getting the joints as supple as possible prior to surgery, but also after surgery, moving as early as you can. And adjunctives to pain medication can be ice packs, as well as the TENS machine, that's transepidermal nerve stimulator. It's a machine where you have, via some gel pads, a stimulus given to the skin. And what that does is it distracts the brain from actually feeling pain, because it's stimulating different nerve fibers and going through a different pathway. And so that can be very effective and reduce the requirement for opioids, which can have side effects such as nausea, vomiting, etc., constipation. So what other things are there on the horizon? Well, we've already started using 3D printing, and we use that if we're trying to make a specialized component. Most components that patients get is something that comes off the shelf. It's already been pre-made, and there are different sizes, I've told you, because we know that the anatomy varies between patients, between different men, between women and men, etc. But if someone has significant deformity, then we can have a specialized implant that's printed. Having captured the data from doing investigations such as CT scans and MRI, information is fed into the computer and a special implant can be made. Implants in the future will be smart. By that, I mean they will have a microchip, and that microchip will be able to detect changes in the microenvironment, such as a change in the pH. So when there's a presence of infection, the normal environment becomes more acidic than it was before. The pH drops, and this will be able to detect that. So, and it detects it at a stage that's quite early, where you may be able to salvage the joint without the need for doing further, more invasive procedures. But it would also be able to detect micro movement. So when the prosthesis starts to loosen, you may, by detecting it early, again, you may be able to salvage the implant. Silver, we've noticed, has bactericidal properties, and so there'll be much more silver being impregnated into implants. And virtual augmented reality is already here, and we're using that to train our surgeons. Before, I mean, when I trained, my boss would go through a case. It was a case of see one, do one. So you would see it, then you would do it with their assistant, and then you'd be doing it on your own. But now we can actually have the trainees go through the procedure without having to touch a patient. So they're well versed in the steps of the procedure, and they can really improve their technique and so on prior to operating on the patient, so that the operative times will be much quicker. And as I said to you, that will then lead to less risk of infection. So in summary, I've just given you a brief overview of how to look after your joints prior to try and prevent arthritis. But once you've had the arthritis, at least hopefully you're more informed as to the treatments that are available to you. And I'd be more than happy to treat any of you should you think it necessary here in the UK. And here are my secretary's details. Thank you very much.
Thank you so much, Dr. Tross. I actually wanted to start off the question and answering with a question, just because at DiagnoStar, one of the things that we do is help organize people who would need to have a procedure be able to travel for this. So one of the things I'm wondering is, if someone were to come to the UK and have a surgery with you, what is the, because in case there are after complications or anything like that, as far as recovery time, because that's an important part of if someone's traveling for medical tourism, to understand, how much time would they need to plan to be away, and what does that kind of full end-to-end time process look like?
Yes. Well, I would recommend that they are around for at least a month. Why? Because in terms of number one, that gives you a time to satisfactorily recover from the surgery and rehabilitate. So you get enough physio on board. But also, in terms of travel, the risk of a deep vein thrombosis is reduced. If you're going to have a long, so I would ideally now, of course, for some patients they can't stay for that long, but that is the time that I would recommend. And in terms of the packages that are available, the packages you'd have to check with the different hospitals because they are slightly different, but they also do cover any unforeseen emergencies that may occur. Now, it would be hoped that when you have a procedure, there'll be no complications. But should there something occur, then the package also covers you for that period of time. I mean, the time varies, but certainly 4 weeks is covered. It may be longer than that. So it covers you during that time as well.
And are you able to, or have you done that in the past? So one of the things that we offer with our electronic medical record basically is the idea is that someone could get some of those tests done here, upload them, and then during your consultation, you'd be able to look through any x-rays or any blood work, any of those sort of things. Would you be able to do those initial consultation to understand whether they definitely needed to travel for the surgery through a
So I would be more than happy to do, yes, a virtual consultation with the patient, making sure that they absolutely do require surgery. I can recommend certain investigations that are done. There are things such as the blood clotting that we want to make sure that's done close to the time of surgery, checking for MRSA, and doing the COVID swabs and so on, which would be done close to the time of surgery. We probably want to do that in the UK, but there's certainly things like the investigations that may be required that can be done at home.
Okay, perfect. That's really helpful because that's one of the things we're trying to coordinate is for someone to have to fly ahead of time and do, spend extra time and money without really knowing that that's definitely what they need to travel for.
Definitely, yes. Happy to help there.
That's good. So I'll pass it over in case any of our other, anyone else on the meeting would like to ask any questions of Dr. Tross at this time. Please go ahead, raise your hand or just go ahead and unmute.
Okay, so I'll just go ahead and unmute everybody. So just feel free to speak when you're ready.
I've silenced them all.
Good day.
Hello. Hello, Dr.
Good day. I'm speaking from Nigeria.
Lovely.
Yes.
Hello.
In the course of your presentation, I have not heard you talking about weight reduction because we observe the patients that are obese are in more chances of developing osteoarthritis.
I think you must have come late. You must have come late to my presentation because that was mentioned at the beginning.
Okay, thank you very much. But what is the chances of, do you take bilateral hip replacement, knee replacement at the same time?
I have done it. I mean, the patient has to be fit enough. It's quite an undertaking. It's a significant stress in the body trying to rehabilitate afterwards. So they have to be fit enough. But if they've got gross deformity in both knees, it's probably worthwhile doing it at the same time.
Yes. What we observe here is that the chances of developing acute renal injuries are very higher when you take the bilateral at the same time.
That's why I said the patient, we have to make sure the patient is fit enough to undergo
fully optimized. Okay, okay. Yes, another thing, you made mention about genotype. Yes, here we notice that most of the patients that go for hip replacement are patients with avascular necrosis of the head of the femur, from sickle cell diseases, steroid abuse. We have them very frequently, most especially that of the sickle cell disease with the avascular necrosis. They used to have them bilateral. And then the chances here too is that you have to take them, staging them because of the low hemoglobin concentration they have. Even their stable hemoglobin PCB are very low. So do you also have similar things in your own place?
Yes, one of my hospitals actually is a center for sickle cell disease, so we do see quite a few patients. We see a lot of other patients with for steroid use for other conditions. They may have a respiratory problem, etc. They've been given steroids for that, and they are presented with avascular necrosis. Sometimes they can get that following trauma, and sometimes I've had patients with avascular necrosis where we've not been able to establish the underlying cause. So it's not an unfrequent or infrequent presentation that I see.
Thank you very much.
If it's early enough, we can do core decompressions, but unfortunately, by the time a lot of them present, it's too late, and joint replacement is the only option that's available.
Similarly here too, we don't pick them at the early stage. We took them at the end stage of FICAT earlier than 4 or 5 at that level that we used to even pick them here. I'm looking for more interactions with your own group. I'm very happy to be part of this presentation.
That's fine. And Dr. Bobby, one thing that I also do with one of the hospitals that I work with is we do have international multidisciplinary meetings. Where we can invite you and members of your hospital to bring your complex cases if you want any sort of help with decision making. And so we do run multidisciplinary meetings where we can discuss our complex cases with a group of surgeons. So if any assistance with you, I'm happy to do that.
I'm very glad to join this group. Thank you very much.
My pleasure.
Thank you.
Okay, for those that can't, yeah, Lindsay. So for those that can't speak, they can make use of the chat box to drop their questions, so that.
Yeah, and that's actually an important thing that you brought up, and that's one of the other things that we've been trying to do is allow local doctors to have platforms like this to access, your team's expertise and just have someone to bounce ideas off of and look at complex cases. So I'll definitely follow up with you about that.
Sure.
That's one of the key things that we're, working on at DiagnoStar. It's not just for, the patients and the clients, but also to kind of uplift the local doctors and their access to information.
Sure. Happy to help.
Thank you so much. Anyone else? We have the chat in another minute. Otherwise, we've taken up quite a bit of Dr. Tross's time today, which we really appreciate you doing. It's really important and impactful for us down here in Nigeria.
My pleasure. I mean, somebody might not have I don't know, is there anything that anyone feels that I haven't covered they wanted me to cover? It was a short time frame, so I didn't want to cover everything. But if there's any burning question, anything that you feel that I haven't covered, then please feel free to ask.
Good evening, Dr. Tross. Thank you very much for this
pleasure.
session. My name is Olubukola. And I just want to find out whether there's any connection between sensation to the foot, right, being felt at the knee and at the hip, just to find out whether there's any, connection within such feeling.
Yeah, I mean, if someone's got pain, hip, knee, and foot, I would be thinking about a spinal cause. You can have hip pathology presenting with just purely knee pain, but you wouldn't get pain below the knee. Pathology in the knee can be felt further down in the lower leg, but it wouldn't give you pain up in the hip. So if you're having problems in all those, it could be that you have more than one coexisting condition, or you'd want to look higher up and think about the spine.
All right, thank you very much.
My pleasure.
I think, Dozier, we can probably wrap up. This is about the amount of time that we wanted to take. I appreciate everyone for coming mostly on time. And we can also, going forward, reach out to us if there's specific topics that you're looking for. I mean, this is just the start of the series for the year. So we're happy to reach out to other, professionals and find other topics that are really relevant. So just let us know, and we're at DiagnoStar, we're always available. And we really, really appreciate your time, Dr. Tross.
It's been a pleasure. Thank you for inviting me.
Okay.
Yeah, Lindsay.
Thank you,
Lindsay.
doctor. Before you leave, so sorry. The
Yes.
question I asked is not actually on the knee, but the back of the knee really is where the sensation is felt. So I don't know whether it's the same thing.
Same thing. Still think
Is the
about the spine. Yeah. If you know, if you have pain just at the back of the knee, then you will be thinking about knee pain can be coming from the knee joint itself or structures bypassing the knee, so it could be a muscular problem. But if the pain is going all the way from hip down to foot, you have to think about the spine.
Okay. Thank you.
Pleasure.
Thank you.
Okay, so Lindsay, just before you wrap up, I would also like to say this webinar will be accessible on our YouTube channel. So just go to YouTube and search for Diagnostic Health. You can always rewatch this webinar. And we still have other webinar series we've had. We still have them on our YouTube channel. So feel free to watch this. And like Lindsay said, if you have any topic that is burning in your mind that you would like us to, just reach out to us. We have a lot of doctors under our cover, so we can always reach out to them and then organize webinars that will suit your interest. So thank you, everyone. Thank you for taking our time to join this webinar. Thank you, Dr. Truss. That was a really nice presentation. Thank you.
My pleasure. Thank you very much. Bye-bye.
Bye. Josie, I was also going to mention to who we have here, if you guys, as I don't know the name, but the person that's titled BLL, you can always set up and get a consultation through DiagnoStar with Dr. Truss. So that's one of the things we offer is the access to doctors abroad and specialists. So feel free to sign up and reach out, and then you can set up a consultation with her in the future. Or
Thank you very much. Thank you. Yeah. Cheers.
Bye.
Thank you. Bye.